KSOS one? No. Which one? Pointer. Pointer here. Mouse pointer. Mouse pointer.
Good afternoon, everyone. We know that neuroimaging, that CT, MRI, always there is a confusion for ophthalmologists what to order, when to order, and how to order. This session will I think this session can help you out of this. The orbit and visual system, we know it's a highly complex system with specialized anatomic features and physiology. So imaging is requested to diagnose the disease that are not amenable to direct visual inspection and ophthalmoscopy. CT and MRI are most useful technique for imaging orbit and visual pathway and CNS pathologies. So questions. Imaging is always expensive and not without risk. So clinicians should address following issues like when to order, what to order, and how to order. Clinical localization and expectation of particular finding should be there, and imaging should have some influence on patient's management, and it should provide accurate diagnosis and better diagnosis. So what to order? Specific choice of imaging modality including the sequence, orientation and direction depends upon suspected location, expected pathology. So MRI we know it's for mainly for the optic nerve pathologies, and CT for fracture, hemorrhage and foreign body. And for aneurysm and carotid dissection and AV malformations, we prefer MR angiography or CT angiography. So errors can be there while ordering. So what are the errors? Prescription or errors, failure to apply a dedicated study, inappropriate use of study and omission of contrast, and interpretation problems. So when you order, ideally communication to the radiologist is vital. Should give complete history, type of scan desired and its sequence, the use of contrast material or not, and other tests like renal function test, scan thickness you have to measure, and area of interest also. So for this, we have with us Dr. Mahesh sir, who needs no introduction. So head of department of Neuro Ophthalmology, Aravind Madurai, and sir will be talking about the clinical aspect of investigations like MRI and CT, when to order, how to order, and what to order, and with its corresponding sequences. And we have Dr. Naga Sai, who is a radiologist, who is talking in the aspect of radiologist view, how they expect us to give an investigation order. For me, I have one presentation COC RetNet session the same time, so I'll be joining back after my session. Let me welcome Dr. Naga Sai, who will be giving the keynote address.
Good evening, everyone. I'm Dr. M. Nagasai, radiologist, consultant radiologist, Metroscans, Kottarakara. Thank you. It's my pleasure and honor to be here in front of all of you. So in today's session, I want to make a few things clear on how to view and how to interpret the basic images of CT and MRI in basic orbital pathologies. So our goal here is to learn how to select a proper modality, CT or an MRI, and learn key imaging findings of common conditions and tailor the imaging requests to clinical symptoms so the radiologist can support your diagnosis. Essential roles of the CT and MRI. CT and MRI both bring their own strengths to the imaging. Basically, CT or an MRI, they always want to highlight whatever that is white in color. CT excels in bone fractures, bony lesions, calcifications, or acute hemorrhages, and further to foreign bodies. Basically, all these things, all these bony things or calcifications appear hyperdense on CT, whereas on MRI, in contrast, it has superior soft tissue contrast, where it can be used for optic nerves, orbital pathway pathologies, tumors or lesions that can compress or orbital pathways, or any pathology that is involving directly the orbital pathway. Let us briefly review the anatomy of orbit and related structures on CT and MRI. This is an axial CT image at the level of orbit. In radiology, the basic imaging is done in three axes: axial, coronal, and sagittal views. Axial images are the horizontal cuts of the body along the plane of the eyes, and the next uh, axis is coronal axis, that is done that acquisition is taken along the plane of the lens or the plane of the shoulders. And sagittal axis is another view. The imaging is done across the plane of the nose, basically. Here we see a CT orbit at the level of orbit in a soft tissue window. And there are two things before starting to know the anatomy. On CT or MRI, whatever you see on the left side of the screen is the right anatomical structure. Whatever you see on the right side of the screen is the left anatomical structure. Because just imagine that there is a person standing opposite in front of you. Then opposite person's right hand will be in your left hand. Opposite person's left hand will be on your right hand. So that is a basic principle. So whenever you are seeing a CT or an MR image, you have to imagine that a person is standing right in front of you, facing you. That gives you the right anatomy. We'll go about the anatomy from anterior to posterior. That is one way to go. And another major principle to look at radiology images is to look for symmetry in every image. We have two orbits here. We have to look at the symmetry in all images. This is an axial image. Will come from the posterior, from the anterior. We have two round symmetrical eye globes here, and anteriorly we have two slightly hyperdense structures. These are the lens, and the midline is the nose. And here we have nice cone formation of the orbits, And posterior to the orbit, this thin, linear, slender structure is optic nerve. And along the edges of the cones, from the edges of the orbits, running along the edge of the orbital cone, we have rectus muscles. Because this is an axial image, we have medial rectus here and lateral rectus here. And these two orbits converge towards medially, and obviously you know the optic nerve pathway and all. Optic nerve, they come into the optic canal and form a chiasmatic region around here. This is cellular region or chiasmatic region around here. And coming to the next image, a little bit upper cuts, a little bit superior cuts. This is at the level of optic canals. You can see the optic nerves that are entering into the optic canal, and they form a chiasma in this region, which we will see more clearly on MRI images. This is a coronal image. Coronal image is taken along the axis of the lens or shoulders. This is like patient is standing straight in front of you. And these are the eyelids. We'll go from anterior to posterior images. These are the eyelids, and these are the orbits, and midline is the nose, and here is the forehead or frontal bone. And let's go a little bit more posterior into that. And we have two symmetrical eye globes here, and four uncoronal images, because we are seeing from the front. Because we are seeing from the front, we can see four extraocular muscles, bilateral symmetrical extraocular muscles, and whatever that appears black in the orbits is all about the intraorbital fat. And below the orbits, we have maxillary sinuses below the floor of orbits, and midline, these are nasal structures, and orbit is surrounded by with the bony structure, bony walls of the orbit. And let us go a little bit more posterior. This is the level at the level of optic nerves. At this level, we can see all the four symmetrical extraocular muscles And medially, we can see the midline nasal septum, nasal structures, and below here is, sorry, this one. Okay. Okay. So this image I just wanted to show you. This is the distinction between CT and an MRI. Basically, you can see this all white thing is all the bone. Bone appears very much hyperdense on the CT, whereas on MRI, you can see the bone is appears very much black in color. And internal brain neural structures you can see very much highlighted in MRI that is not possible on CT. And coming to the MRI, these are the basic sequences T1 and T2. So how to differentiate between the T1 and T2? There are two, let us make it simple. There are two main components on how to differentiate T1 and T2. One is water and another one is fat. Water is CSF and vitreous. Another is fat. We'll first talk about water. Vitreous is water. In T1, it's darker in color. On T2, water is white. It is brighter in color. On T2, water appears white, like we used to study in the MBBS studies, World War II, water white 2, water appears on white on T2 like that. This is T1, water appears dark. This is T2, vitreous appears white. And fat, coming to fat appears bright on both T1 and T2. Slightly iso-intense, slightly not so white on T2, but very much whiter on T1. And in orbit, what is most important to view intraorbital structures is to nullify this signal, white color fat signal, and make it as fat saturated images. This is just a table to tell you, on T1 vitreous water appears black, fat appears white. But on T1 fat saturation images, it's a T1, vitreous appears black, it's a fat saturated image, fat also appears black. On T2, vitreous appears white, fat also appears white. On T2 fat sat images, vitreous water appears white, fat appears black. Let's see the images. This is the T1 image, we have seen the image. And let us review the same anatomy that we reviewed on axial CT images. Same, this is the long, slender, thin optic nerve. See the symmetry over here, and see the symmetry of extraocular muscles also here. Medial rectus and the lateral rectus, and the midline sphenoid sinuses, and posteriorly this is a cellular structure, and posterior to that we have midbrain and brain structures. This is fat sat image of T1. Water is dark, vitreous is dark. Posterior to that we should be seeing the fat which is white in color. Because it's a fat sat image, fat also appears black in color. And this is T2 image that we have seen. And let us learn a small point about anatomy here. As we are coming posterior into the cellular region, this is the cellular region. This black color structure that you see on the both sides, it's called as a flow void. That is because of the internal carotid artery on both sides of the cella at the level of cavernous sinuses. So identifying this black color structure in the T2 images or T1 images is essential, because that is where we look for any cavernous sinus anatomy or related pathologies. And this is T2 fat sat image. T2 water vitreous appears white and fat is attenuated and appears darker. You can see this thin, slender optic nerves here in the optic canal and go into the chiasmatic region. In next upper section, we have bilateral symmetrical cavernous sinuses with the internal carotid arteries. And in this, we can see the X-shaped forming optic chiasma. And posterior to that, here we have optic tracts that continue as optic radiations. And this is the coronal images of the same extraocular muscles, symmetrical appearance, optic nerves. Posterior to that, this is at the level of optic canal. And posterior to that, we have cella and bilateral. These two flowers that we see on dark structures are about the cavernous sinuses. And center, we can see the pituitary gland over here. And above that is the pituitary. These small structures are the optic nerves, intracranial optic nerves, combining to form an optic chiasma. Optic chiasma in coronal T2 image appear as flat disc-shaped structures just above the level of pituitary. On identifying optic chiasma, coronal T2 images are essential. 3 to 4 mm cuts are essential, and avoiding partial volume artifacts can be avoided by thin cuts and correct positioning. When you see the pituitary gland, just superior to that, there is optic chiasma in sagittal or coronal image, which appears as a a flat disc-like structure. And posterior to that, we have optic tracts over here and the CSF around here. And these are the sagittal images. From sagittal images, we'll go from lateral to the medial. This is the lateralmost section. This is the lateralmost section of the orbit, and here is the temporal lobe. Posteriorly, we have brainstem here, and little bit more medially, we have orbit here, nice lens here, superior rectus, inferior rectus, and the clivus region, cellular region, and the brainstem. And more in the midline, more towards the midline, this is how cella appears with the pituitary gland. And above that, superiorly, we see this horizontal flat disc-shaped structure that is optic chiasma in the sagittal images. Posterior to that, we have brainstem and cerebellum. This image I want to show you just to differentiate the pre-contrast and post-contrast images. This is a pre-contrast image, T1 fat-sat image, and that is a post-contrast image. If you can see, extraocular muscles are nicely enhancing over here, and optic nerves as such, they do not enhance much. Coming to the cranial nerves, cranial nerve anatomy is we know the pathways from midbrain to the interpeduncular system and the cavernous sinuses. Let's watch a small video about it. Oculomotor nerve from the interpeduncular system, from the peduncle, it goes into the interpeduncular system here, and goes into the cavernous sinus here. I hope the video is clear. Okay. And next comes to the fourth trochlear nerve. It comes from the dorsal side of the midbrain and goes around the midbrain in the ambient systems, and along the third cranial nerve, it goes into the cavernous sinuses. Let's watch a small video about it. The trochlear nerve here arises from the dorsal aspect, courses along the ambient systems here, and along the tentorium. Basically, these third and fourth cranial nerves pass between the adjacent PCA and PCOM arteries, whereas fourth cranial nerve between PCA and SCA, and there it goes into the optic cavernous sinus. And coming to the abducens nerve, this comes from the pontomedullary junction, travels for some distance in prepontine system along the clivus, then enters the Dorelus canal, and then goes into the cavernous sinus. Let's see a small video of it. Here is the pontomedullary junction. You can see the opposite one. It is going here. It is traveling along the prepontine system. There's a small structure, very slender structures. These are the Fiesta sequence images, heavy T2 images that are useful. And here you can see that is entering into the cavernous sinus here. Sixth cranial nerve has the longest course, as you know. So basically, when you try to find pathologies related to cranial nerves, you don't actually look at the nerve, but you need to see at the pathway that that the nerve courses along. So in third cranial nerve palsies, most common pathologies are posterior cerebral artery or posterior communicating artery aneurysms, and from the source there can be midbrain infarcts. And coming to fourth cranial nerve palsies, most common are dorsal midbrain lesions. And sixth cranial nerve palsies, because of increased intracranial pressure, idiopathic intracranial hypertension, or petrous apex lesions or clival lesions that can cause the palsy of sixth cranial nerve. And this is the MRI imaging protocol, as we have discussed already: T1 anatomy, T1, T2, T2FS, and flare imaging for the brain, and DWA or EDC for acute ischemias, and Fiesta particularly for the cranial nerves, and any small lesions we can detect on Fiesta sequences. And post-contrast T1 fat-sat images are essential, and optional are MRV and MRA, and dynamic contrast based on the anatomical pathology that we are suspecting. Okay, this table shortly comprises of basic presentations and the likely diagnosis that you expect from us, and the basic and the mode of modality that you can order. So when there is sudden painful vision loss, monocular vision loss, it could be primary optic nerve pathologies. We can go for the Amara orbits with contrast and screening brain. Binocular vision loss, most correctly cortical or subcortical pathology, we should go for MRI brain first. If not available, we should screen with CT brain. And diplopia, Cranial nerves, cranial nerve palsies, as we know, because CT angiography or MRI angiography should be done for any cranial nerve palsies. Along with that, MRI brain and orbit should also be taken. And proptosis has a number of causes: infections, tumors, or vascular. You can go with CT or a CT orbit or MRI orbit, depending on the presentation. Because if it's a trauma case, sudden head loss and proptosis, you should go for CT first, then we have to go for MRI. If it's a soft tissue lesion that you're suspecting, you should go for the MRI orbit first. And optic disc swelling, papilledema, idiopathic intracranial hypertension, or any venous thrombosis can be the cause. You should go for MRI brain and MRV. And visual field defects that are chiasmal and retrochiasmal pathologies, you should go for MRI cella or MRI brain. So let us quickly go through a few cases. As we discuss the anatomy, we will discuss a few cases from anterior to posterior direction. Optic nerve pathologists, we will see a few images. After that, chiasmal pathologists. After that, optical orbital apex or cavernous sinus pathologists, retrochiasmal pathologists, and then we will see some brainstem abnormalities and cranial nerve palsies. So 4 easy steps to view any image. First, you have to know what you are viewing at. Axial image, or are you viewing a coronal image, or are you viewing a sagittal image? Once you know the axis of the image that you are seeing, you have to know which is right and which is left. And after that, you have to read any image in a particular direction and not randomly search for any positive finding in any image. Either you have to go from anterior to posterior direction in axial and sagittal images, and in coronal images, you should come from superior to posterior. Or based on the anatomy that you can follow, you have to read any image in a proper direction. And in radiology, most important point, especially for orbits, is to always look for asymmetry. If the loss of symmetry itself shows us many findings in CT or MRI. So first case, 30-year-old female with sudden onset of painful eye movements and blurring of vision since one day. This is the T1 weighted image. Check for the symmetry. Here there is the optic nerve on the right side. Here is the optic nerve on the left side. On the left side, it appears little thickened. And this is a T2 image, same. On the right side, it appears normal. On the left side, it appears more white or more dark, more whiter in color and slightly thickened. Posterior cellular structures, chiasmatic structures, brain stem structures, everything appear normal. This is the DW image. And next we come to the post-contrast coronal images. You can see nicely symmetrical appearance of extraocular muscles on the both sides, but in the center, optic nerve is not enhancing on the right side. Optic nerve is enhancing on the left side here, and it is thickened. The same you can see the loss of symmetry. Right side is normal, left side is abnormal. This is a case of left optic neuritis. Now, left optic neuritis is many of the times related to cases like multiple sclerosis and neuromyelitis optica. This images is to just show you how the demyelinating lesions in brain appear. This is a FLAIR image of brain showing white demyelinating lesions in white matter, which we call as Dawson's fingers. And this is an image of spine, cervical spine especially. And you can see here where I'm pointing, this is the normal spine here. This is the normal appearance of the spine. Above and below that, the spinal cord is expanded with the white color hyperintense lesions. These kind of lesions in the setting of optic neuritis are seen in neuromyelitis optica. Next patient, 40-year-old male with progressive right eye painless proptosis. First image, sagittal image, orbit, nice. Posterior to that, optic nerve, not very nice. There is some lesion here. Go to the T2. T2 sequence, again, there is some lesion around the optic nerve. Come to the RC sequence. Coronal image, compare the symmetry. Here there is a lesion, but here there is something hypointense like the optic nerve. Here optic nerve is pushed infromedially here. There is a lesion around the optic nerve is pushed infromedially. Post-contrast images, nice enhancement. On post-contrast axial images, this is what we call as tram track sign or train track sign. Because of the enhancing nerve sheaths and non-enhancing nerve itself, this image shows you the tram track sign. And if you can see, the symmetry is again lost over in this region, in the orbital apex region. This is a case of optic nerve meningioma. This is a sagittal image on CT, and just to show you the tram track sign. And this is a case of, we have seen the optic nerve meningioma. Let us just see the cellular meningioma cases. This is a case of cellular meningioma. You can see meningiomas are the tumors of brain layers that are a dural sheath layer tumors. And these meningiomas have always a broad base towards the dura. This is a case of a mildly enhancing lesion. This is a meningioma. Why it is not a pituitary lesion is because there is a small enhancing gland over here, which does not look like the mass over here. Here, the pituitary gland is being compressed inferiorly, and because of the appearance and anatomy, because of the broad base, this is an cellular meningioma centered on tuberculum cella. A 2-year-old recently noticed left eye proptosis. Axial image, left eye, orbit is nice, optic nerve, symmetry lost, swollen, and T2 completely swollen, totally hyperintense. But on fat set images, you can clearly appreciate the swelling of optic nerve in the intraorbital course. On post-contrast images, it is seen enhancing nicely, not like the meningioma, not showing any tram track appearance, lesion itself is arising from optic nerve. This is a case of optic nerve glioma. And gliomas can occur anywhere along the orbital pathway. And here, where I shown you chiasma region at the level of cella, the two beautiful flowoids which represent cavernous sinuses here. We must have seen the chiasma here, but there is no chiasma, and there is a small pituitary gland also here, if you can appreciate. So optic chiasma itself is not seen, and it's an axial images also you can appreciate the X-shaped chiasma, which is not appearing normal but is swollen. This is a case of optochiasmatic glioma involving intracranial courses of optic nerves and chiasma, and also optic tracts also. Another case, 34-year-old male, headache and papilledema. Primary thing, idiopathic intracranial hypertension we suspect. What are the features of idiopathic intracranial hypertension that we should look out for? First, in orbits. In orbits, because of increased intracranial pressure, or CSF sheath along the optic nerves tries to distend. It distends it, and optic nerve along its width increases, and it appears bilaterally symmetrical on both sides. Increase in optic nerve sheath diameter is an indication of idiopathic intracranial hypertension. Another feature is cella. Looking at the cella is fully filled with CSF, and pituitary is compressed here. This is known as empty cella, which can be seen incidentally also in normal patients also, but it is a feature of, if it is clinically, if you are suspecting idiopathic intracranial hypertension, this is a positive finding for it. And another, this is an image of MRV. An increased intracranial pressure, transverse sinuses are the most common ones to get stenosed, not because of thrombosis, because of stenosis. But because of thrombosis also, idiopathic intracranial hypertension can occur. And in thrombosis, these are the white structures here are all the dural venous sinuses. In thrombosis, you will not be able to appreciate these sinuses based on the anatomical involvement. And let's see a few trauma-related images. This is how foreign bodies appear on CT. Nice hyperdense objects. Based on the composition, most of the foreign bodies appear hyperdense. And compare. This is another trauma image. Compare on the both sides. 4 walls of the orbits here. 4 walls of the orbits here. Orbital is looking nice here. Orbit is looking here, and there is optic nerve here. And floor, coming to the floor of the orbit. Floor of the orbit is looking asymmetric on the left side. Break on the left side. Little bit of fat herniation inferiorly. This is blowout fracture of orbital wall. Let us go to this is also a trauma case, CT image in a case of trauma setting. You can see asymmetric thickening of optic nerve itself that is appearing very much hyperdense on CT, which we do not see like this. Optic nerve, even if it's thickened, we do not see it this much hyperdense on CT. This in a trauma setting is this suggestive of optic nerve sheath or optic nerve hematoma. Then we have to suspect based on the vision loss. We have to rule out. We have to suggest MRI also to rule out optic nerve transection or anything. And another thing, coming to the bone, this is a bone window to look for optic canal fractures. This is the case of optic canal fracture. Look for the symmetry here. This is optic canal, wide open, nice. On the right side, narrowed. This is the broken piece of bone. And in trauma cases, always we have to look at coronal and sagittal images. On coronal images, symmetry gone. Here bone fragment impinging onto the optic nerve. Sagittal also same. Here small bone fragment is impinging onto the optic nerve. So identifying optic canal fractures, CT should be the gold. CT is the gold standard. You should view in the bone windows only. Thin sections are mandatory to look for optic canal fractures. Coronal and sagittal, and always look for asymmetry between the on both sides. And another case, bilateral proptosis, 50-year-old diplopia since few months. CT image, extraocular muscles are enlarged, symmetrical enlargement, and posterior to that at the level of, just anterior to the level of orbital apex, enlarged, compressing the optic nerve here. Same appearance, same thing on axial images. We have seen normal MRI, so normal CT image, how extraocular muscles appear. We are seeing now how enlarged muscles appear over here, which are bilaterally symmetrical involvement. This is a case of, same on the MRI also. This is the case of thyroid eye ophthalmopathy. This is the differential pseudotumor of orbit, where tendon is also involved, where tendon is paired in thyroid eye ophthalmopathy. And this is Barrett's index, the radiological quantitative index to quantify the compression of optic nerve, which is to quantify dysthyroid optic neuropathy or compressive optic neuropathy. Basically, according to this index, any horizontal or vertical index, if it is more than 60%, then it is most likely compressing the optic nerve. It should cause some symptoms. Another case, quickly we'll move around. Recurrent headaches, 40-year-old visual field disturbances. Well, coming to cella, here we are seeing cella, two nice black structures here at the level of cella, on the other side of cella. T1 image, some lesion in cella. Sagittal image, cella is expanded. Here white color thing is the clivus. Here is the sphenoid sinus. Here is the cellular lesion on T1. Next, coming to the T2, there's a cellular lesion. The flat disc-like structure we have seen earlier, here it is being compressed superiorly, and it's because of this lesion that is occupying cella, and we can't see any pituitary gland here separately. On post-contrast images, lesion is appearing homogeneously enhancing and is also involving left cavernous sinus. This is a case of pituitary macroadenoma. Let us look at a few another cases of cellular lesions, particularly pituitary lesions. This is a solid cystic lesion of in the region of cella in an 80-year-old. This is the same case. In the post-contrast image, it shows nice enhancement of solid areas and non-enhancing cystic areas. On CT, if you take a CT, there are calcifications in this case. This is an indication of, this is suggestive of craniopharyngioma. Another differential, a purely cystic lesion in the cella is the Radcliffe's cleft cyst. Another case, 38-year-old with headache, fever, presented with altered mental status and sudden onset partial vision loss. Let us go to the T1 post-contrast. There is diffuse enhancement around the cavernous sinuses and these linear enhancing structures, those are meninges. You can see very much nicely in the coronal image, they're appearing like layers of linear hyperintense enhancing areas along the optic cavernous sinuses here and along the brain lining. This is a case of TB, tuberculous meningitis involving cella and cavernous sinuses. Next, 80-year-old female, recurrent attacks of blurring of vision and vertigo. You can see at the level of cornea, at the level of cavernous sinuses, there is some asymmetrical mixed signal intensity lesion on the right side, and same on the coronal images. At the level of where we have to see the flow void of ICA, we are not seeing any flow void here, but there is a large mixed signal intensity lesion. If we give a CT angiography, if we do a CT angiography for this case, it appears as a ballooned out, brightly enhancing lesion on arterial face, which is symmetrical and positionally symmetrical to the opposite side, internal carotid artery. This is a case of internal carotid artery aneurysm seen on CT, which you can see better on coronal images. This is the cavernous sinus ICA, and this is the dilated ICA on the right side. Next, history of trauma and left exophthalmos, left proptosis. First image, prominent flow void, which is not seen on the right, seen on the left. Superior sections, prominent flow void, superior ophthalmic vein is prominent here. And if you see at the cavernous sinuses, single nice flow void, but there are multiple flow voids on the right side. Contrast, enhancement, and also there are multiple enhancing under vessels over here, and also intraorbital there is something enhancing. This is the superior ophthalmic vein. This is a reconstructed image. You can see right side, simple, normal, and left side from the carotid ICA, and there is some enhancement in cavernous sinus and enhancement of superior ophthalmic vein. This is a case of carotico-cavernous fistula. Another case, 46-year-old, painful ophthalmoplegia, complete ptosis, diplopia, something we are looking at all third, fourth, and sixth cranial nerve palsies. Some mixed signal intensity, if you can appreciate this, on left side, little bit hyper-intense areas at the level of orbital apex. On axial images, you can very much appreciate the enhancement around the orbital apex. And this is another image, enhancement around the optical apex because of the inflammation around the orbital apex. This is how it appears, and this is a case of Tolosa-Hunt syndrome. Another case, 68-year-old, posterior headache, dizziness, sudden onset partial loss of vision in both eyes. CT, screening CT showed ill-defined hypodense area. This is a PCA territory infarct. This is how infarct appears on CT. On MRI, it appears diffusely edematous tissue, which appears hyperintense on DWI and other sequences as well. DWI is the essential and number one sequence to look for any acute or hyperacute infarcts. This is a DWI image. DWI image itself, it highlights everything that is acute or hyperacute infarct as early as possible. Another case, 50-year-old male, progressive headache, facial numbness, progressive sixth cranial nerve palsy. So we are looking at something lesion that is involving sixth cranial nerve, but we are looking something at the region of sella. But look closely. It's involving sella and is also abutting basilar artery and pons posteriorly. And it's enhancing nicely. Now, if we really think it's a cellular lesion, but look at here clearly, the clivus is not seen here clearly. The lesion is also involving clivus. Basically, this is a case of clival chordoma involving the cella and involving the tuberculum. This is the case of clival chordoma. Another 72-year-old male who developed sudden onset dysarthria, pupil sparing oculomotor nerve palsy, and left-sided ataxia. We are looking at something in the oculomotor nerve palsy, pupillary sparing. We are looking something into the midbrain. Here, our target area is the midbrain. You can see asymmetrically hyperintense area here, and on diffusion-weighted imaging, there is a hyperintense area on DWI here. This is a case of medial ventromedial midbrain infarct, also known as Claude's syndrome. And 42-year-old male with right oculomotor nerve palsy. This is subtle finding case. This small black structure, which is not seen on the right, which is not seen on the left side, is seen on the right side, which is more clearly seen on Fiesta imaging, Fiesta sequences. And on post-contrast images, there is small outpoaching here, and this is a case of posterior communicating artery aneurysm case. And this is an image of MRA in a particular section in a view. This small hyperintense pouching-like structure is the aneurysm along the PCA. And this is also a case of PCOM aneurysm, but this is on the left side. The key takeaway points are CT is for the blown blood and foreign bodies, MRI is for the nerves, soft tissue, and inflammations. And we have to use targeted imaging protocols. If you are suspecting any cranial nerves, you have to ask for a Fiesta, and also if any lesions or any inflammatory things, you have to ask for a contrast as well. Match the imaging with symptoms. No critical neuro-ophthalmic anatomy. Use CTA, MRA, or MRV whenever vascular cause is suspected. And CT is essential in emergencies, and communication with radiologist for targeted imaging. Thank you. Welcome to Grayscale World.
Thank you, Dr. Sai. So it was a very excellent lecture, and I learned a lot. Even after 25 years, I still could take a lot of points, valuable points from you. So I have a few doubts to ask you.
Yes, sir.
For the benefit of the audience, what is DWI imaging?
DWI imaging is basically, it is diffusion-weighted imaging, sir. Diffusion means whenever the water molecules move around, it doesn't pick up the signal. When the water molecules are not moving around, that means when edema or when any cytotoxic edema or packed cellularity in a lesion, there is no much movement of water. And because of not much movement of water, there is no magnetization uptake and less of recovery. So whatever doesn't move, water doesn't move when there is diffusion is not there. When the diffusion is restricted, when the diffusion is not there, that appears as hyperintense structure in DWI, sir.
Okay, so that will appear in ischemia and infarct.
Yes, sir. Yes, sir. It appears in ischemia or infarcts basically, sir. Yes,
okay.
sir.
Any questions from the audience? So, okay. Thank you, sir. First, so I am not a radiologist, so I thank Dr. Gemini for having invited me and KSOS. So yes, I thank Dr. Sai for excellent overview. So I request you to clear our doubts even after this, if any. So I'll quickly run through it. We have limited time, and essentially it contains all the things. It will be a repetition. So I will take it as a quiz rather than anything else. It's all, I'm doing only cases, and many cases have been shown already. So it's just a quiz. First, congenital anomalies. One congenital anomaly which I would like to stress here for the ophthalmologists is optic nerve hypoplasia. You can see the double ring sign, optic nerve hypoplasia. Now why does it matter? It is anyway hypoplastic, vision is less or normal. Now why do we bother? It's a congenital condition, but we should bother. So in the imaging you can see the thinned out nerve, and also you can see normally whenever there is an optic atrophy, the nerve will be thinned out, but correspondingly the CSF will be widened out because the CSF space will be normal as before. But here the entire structure is thinned out. That is optic nerve hypoplasia. But that it doesn't end there. What is more important is a condition called as septo-optic dysplasia or de-Mortius syndrome. These are a lot of findings in this. One thing you should know is there is a absence of septum pellucidum. So what the radiologists call as box squaring of the ventricles. You can see the posterior ectopic posterior pituitary. Sir showed a lot of chiasma and other things. We have the chiasma here. This is a ectopic posterior pituitary. Normally the posterior pituitary is bright because of fat. Without contrast it will be bright. Anterior pituitary will not be bright. But without contrast you can see the bright signal which is ectopic pituitary in septo-optic dysplasia. These are all other radiological findings like we don't need to go into that. So we should know this because these children will have hypopituitarism. So we should identify this and we should refer to the endocrinologist or the physician. That's why we should care about optic nerve hypoplasia. So now we should not have given the diagnosis. So now what is the clinical finding is plexiform neurofibromatosis. Plexiform neurofibromatosis, it's type 1 neurofibromatosis type 1. You can see the absence of the greater wing of the sphenoid and the pulsatile proptosis and other things you will have. And what is this condition for ophthalmoscopically? Morning glory, you can see it resembles the morning glory flower, and they will have basal encephalocele. So these are the reasons why we should care about congenital optic nerve anomalies. We should care. We have to detect all these conditions. Now this is this again Dr. Sai has described multiple nerve palsies. You can see the Tolles-Ahern syndrome, inflammatory lesion. One point for us ophthalmologist I want to give is this is very glaring in this axial section. Always also look at the coronal section. Coronal section gives a differentiation very grossly, and with this you can clearly see that this area is more hyperintense than this area. Now sarcoidosis has various manifestations to us. It can be optic neuritis, it can be uveitis, so many other things. You can see the sarcoid granulomas in the optic nerve. It can present as optic perineuritis and other things. So you can see the extensive inflammation within the visual pathway. Now again this has been described. So Dr. Sai showed one beautiful dilated superior ophthalmic vein. So for us ophthalmologists we should know that SOV goes from lateral to medial in the upper part of the orbit. So now this is a very gross finding, but any subtle findings, any subtle proptosis, subtle CCF, indirect CCF also we should be able to identify. So this is a gross CCF, you can see the dilated SOV, and this is a chemosis, and direct CCF, this is a case of direct CCF, usually due to trauma. One point I want to tell us is, we had one patient who had a trauma, he was declared normal, 2 months later he is coming to us with a 6th nerve palsy. Now what is the reason? Initially scan has been taken, everything is normal. Can we say that, okay, this is something maybe due to diabetes or something? Can we say and let him go? We should not. Whenever there is a trauma, we should suspect, if it develops late, we should suspect a direct CCF. Why did it not develop before itself? Because at that time the rent is very small between the internal carotid artery and the cavernous sinus. So gradually in the course of time, the rent becomes bigger, and directly to show up to us with a 6th nerve palsy, or sometimes even 3rd nerve we have seen. delayed presentation. Always repeat the imaging. Suspect delayed CCF, direct CCF in a case of trauma. Now this is primary optic atrophy. So can we say POA, nothing can be done, long standing? We cannot say that. We need to do the fields if possible. Vision is normal. Vision is reasonably good, 6/60. And we should do some form of neuroimaging. So now, 25 years back when I was a PG, and I'm sure some of my counterparts might be here, that time X-ray only. CT scan was 1,500 rupees. That time my stipend was also 1,000 rupees. You can know this thing. It was very difficult. 1,500 was a big amount those days. Okay, so we will try to avoid CT as much as possible. MRI is out of question. So we used to do a lot of X-rays. So nowadays PGs do not know what an X-ray is. It is an outdated investigation, but there are a lot of valuable information in the X-ray. So you can see the cella, well preserved anterior clinoid and the posterior clinoid, but you can see some amount of hyper density in the basis sphenoid, in the planum sphenoidal region. Of course, this is not enough. But this says that something else may be going on. You can see the dilated meningeal vessels. And now this is a CT plane study, and you see that this is a supracellular cistern. It appears to be normal, but the cistern is filled because there is something else going on here. You see, this is a bright contrast enhancing tumor, a meningioma. This is a isodense. Iso means it is similar to the surrounding brain tissue. So never be willing to accept a CT scan without a contrast. You can very well miss. Look at the supracellular cisterns. Ideally, we are doing nowadays MRI only, but if at all a CT is there, make sure that it is contrast enhanced. So this is again meningioma. Why not it is a pituitary? Because the cellular fossa is not really enlarged and it is more supracellular, slightly asymmetric to one side. And Dr. Radiologist showed that you can see it is extending along the planum sphenoidal, and sometimes you can see what is called as the dural tail sign, enhancing dura along the meninges. And you can see the hyperostosis of the bones because of the chronicity of the lesion. So sometimes you can see this hyperostosis. So that is a supracellular planum sphenoidal meningioma. Next case is a bitemporal hemianopia. Again, it presents with a bitemporal pallor, but here you see the X-ray. You can see the double flooring of the cella. So something is going on in the cellular region, and you can see this is a cellular mass, pituitary mass, which is in the midline structure, which again has been shown. You can see this is a CT, and you see the notch here. There is a small notch here. Why that notch? Because the pituitary grows, pierces the diaphragm, and again it grows. So when you ask them, they will say, 6 months back I had headache, now no headache. When it was piercing the diaphragm, they would have had headache. Now in the supracellular space is very big, so they don't have headache now. So this notch is when piercing the diaphragm, and this shape roughly resembles a figure of 8 appearance, they call it, or a snowman appearance. See, like a snowman, you would have seen this Tintin comics, Tintin in Tibet or something you would have seen. So like a snowman in the Himalayas or a figure of 8 appearance. You can see the notch here, and this is a pituitary adenoma which is engulfing, as was shown by the radiologist, the internal carotid artery. Macroadenoma. Now, as clinicians, my chief used to scold us if we don't identify the clinical findings. Now, we have to identify this patient only by the clinical findings. Now, it is obvious. He has got prognathism, he has got thick lips, he has got hypertrophied frontal area. It is an obvious case of a growth hormone excess. So, similarly, opposite to this, when the patient comes, a 25-year-old adult or a 30-year-old adult comes to us with the male gas, no mush, he appears like a 18-year-old boy. And many times they would have had no children, infertility, they would have been extensively investigated, the wife would have been investigated, so many things. But this guy will be like a young adult or a young adolescent boy, but he'll be around 30 years old. Once I took such a case to my madam, and she scolded me, did you ask for secondary sexual characters? Did you see the pubic hair, whether it is grown or not? I didn't. So I got very heavy scoldings. So these are the things we should know as a clinician. We should look at all the clinical findings for any PG who may be here. I am not sure whether PGs are here. So this is a case of acromegaly. So, and you can see the hypertrophied frontal sinuses and large cellular area, double flooring of the cella. And after tumor excision, residual, you can see the chiasma, some residual mass is there. Usually they give radiotherapy. So that's a growth hormone growing. So this is a multiple cranial nerve palsy. So now you see the total ptosis. You can see this you see the pupils. Pupils are dilated and fixed. You can see total ophthalmoplegia, adduction, right side. Adduction is limited. All the other movements are limited. It's a proptosis. So it is a case of a orbital apex syndrome or a cavernous sinus syndrome. And this similar case was shown prior by our radiologist. And this is an aneurysm, a large internal carotid artery aneurysm which is thrombosed. Sir, correct me if I'm wrong, if I make any mistake, any image. Okay, is this correct? Thrombosed aneurysm. Okay. So now again in the MR angiogram, and we all know this aneurysm presses externally on the pupil fibers. And next is a young middle-aged female with ophthalmoplegia and proptosis. And for the PGs, you can see here there's some amount of chemosis, some amount of lid edema. So this is telling that something, it is not a straightforward inflammatory case. And her blood sugar was 400 mg/%. Now what is the diagnosis? Is it an inflammatory orbital apex syndrome? Likely not. You can see now, we can see the dilated superior ophthalmic vein here as compared to this. And you can see the axial view dilated superior ophthalmic vein. And what else can you see here? You can see this is a cavernous sinus and there is a filling defect. You see the opposite cavernous sinus and here there is a filling defect. Now she has got a high blood sugar and proptosis, ophthalmoplegia. We have to make a diagnosis of a cavernous sinus thrombosis. We should not give steroids here. Next, multiple sclerosis has been shown, either normal fundus or an optic disc edema. Sir has shown the Dawson's fingers, perpendicular fingers and the skipped lesions in the spinal cord. All these white matter lesions has been seen. And these are another type of tumefactive necrosis in a multiple sclerosis patients. It's good to know, as ophthalmologists, it's good to know some of these things. Papilledema we have seen, you can see the dilated optic nerve in the CT, but MRI will show the CSF as well as the nerve. There's a dilated perioptic nerve space which is seen in the CT with in the MRI T2 sequence. You can see, whereas CT you cannot differentiate the nerve and the CSF surrounding. And you can see the dilated perioptic nerve sheath. And early papilledema we have seen, mild papilledema. Now there is a fallacy here. Any papilledema can potentially harbor a venous sinus thrombosis. Now this is a case of in a CT of venous sinus thrombosis. You can see hyperdense lesions here and hyperdense lesions here. But ideally we should do an MRI scan. And here in this CT you can see a filling defect with contrast. This is without a contrast, plain study. And if you put a contrast in a CT, you can see a filling defect. It's called an empty delta sign. And you can also see the superior sagittal sinus, a tram track sign due to the filling defect in the superior sagittal sinus. In an MR venogram, this is a normal venogram. You can see the absent signals, the MR venogram. And MR venogram is ideally, it's a non-contrast study, but nowadays they put contrast also, they give. Now this is seizures followed by field defect and homonymous hemianopia. So any seizures, any in the occipital lobe or in the parietal lobe, in the intracranial lesions, you can see what is here is a cysticercosis. So it is a cysticercosis in the posterior parietal lobe, which is causing the field defect as well as the seizures. And again, this is a diffusion weighted hyperacute infarct in the right occipital lobe, which is which may be showing a left homonymous hemianopia, which is sudden cortical blindness, bilateral sudden vision loss due to cortical visual impairment. Thank you very much for your kind attention. So since Dr. Gemini is not there, she had to go for for her presentation. I thank all the participants here for having come to our instruction course. And as ophthalmologists, let us all be proficient in imaging also. I thank our invited guest speaker, radiologist Dr. Sai. Thank you for your kind presence here. Thank you.